considering all things, we are very much concerned about the infectious causes, and among infectious causes, we are very much concerned about the more common diseases which can spread from one person to another. Those diseases are called as communicable disease. Okay. Now, causes of viral hepatitis have been taught to you. There is a particular group of viruses which specifically infects the liver. Those are called as hepatitis viruses. Okay. And there are other groups of viruses which may cause infection at other system or a generalized infection. Along with that, the liver might be affected. Okay. For example, a very common is, suppose considering a cytomegalovirus or a dengue virus, it causes systemic infection. It causes inflammation in many parts of the body, among them liver is one of them. But when we say as hepatitis viruses, they specifically infects the liver, and when it infects the liver, it causes derangement of the liver function. Okay. Problem is that not only the liver function is deranged, but also the liver gross morphology and microscopic morphology is also altered. They have acute consequences and also have chronic consequences. Okay. Now, I think because you have been taught in your lecture classes, what are the hepatitis viruses? A, B, C, D, E, and there are many more, but we are predominantly concerned with these 5 viruses because they commonly affect the people much more. Now, why we are very much interested in B and C? Because B and C spreads through many routes. A and E predominantly spreads through the fecal-oral route, whereas B, C and D is transmitted by parenteral route. When I say parenteral route, that means other than the enteric route. So, commonly through blood and blood products and also sexual route of transmission. Okay. Now, please remember, when we tell you about needle stick injury or occupational hazard, the predominant disease that comes to our mind is HIV. But studies have shown that the possibility of transmission of HIV from a needle prick or a blood or secretive products to another person is proportionately much lesser. The chances of transmission of hepatitis viruses are even higher. Okay. So, whenever there is an episode of a needle stick injury or an occupational exposure, always keep these 2 viruses in mind. Okay. Next, why these are important? Because if you look at the prevalence of the disease, in India, there is a high prevalence of hepatitis B and C infection, predominantly by sexual and blood product route, and the other more commonly are hepatitis A and hepatitis E. You might have commonly heard that some people, especially in your surroundings, small kids are getting a called episode of jaundice, and then after 2 to 3 weeks they become better. So, that those are very commonly caused by hepatitis A. Generally, it is not very of dire consequences, but sometimes it may spread to many people at a local area. And studies have shown many human beings or people in India are affected with hepatitis A. Similarly, hepatitis E also causes hepatitis, but it causes what is known as fulminant hepatitis in pregnant women. Why? In pregnancy, I have already told you, is a immune suppressive condition. In that scenario, it causes fulminant hepatitis. Many a times it is also fatal. Now, as I have already told you, the route of transmission is by fecal-oral route. Now, the government of India has already launched a program for control of hepatitis viral hepatitis in India. Now, because you have all read about the hepatitis, how many of these infections are vaccine preventable? Any idea? Of the 5 predominant hepatitis viruses, how many are can be prevented by vaccines? See, there is a established vaccine for hepatitis A. There is a vaccine for hepatitis B, but at present there is no vaccine for hepatitis E. And because hepatitis E transmit through fecal-oral route, so we have to block the chain of transmission. This is the reason why the government of India have made many programs, national programs like the Swachh Bharat mission, okay, and one more is Swachh Jal mission, that is to provide safe drinking water to, the target is to provide safe drinking water to all people of the country, and along with that there is universal providing toilet facility to everyone in the country. All these programs, the objective is to stop the transmission of the fecal-oral route. Okay. Now, why I am telling you all this? Because see, we do have a national program for control of hepatitis, viral hepatitis infections, but the program cannot run singly because it's a problem of the whole population. So, these national programs are also important. For example, the river water pollution control, I think you have heard about some of the programs like control of water pollution in the river Ganges and other rivers, because the rivers are the main predominant source of water. Okay. So, these are all part and parcel. Among them, I think biomedical waste management rules and handling, you have already read about that. Safe injection practices, universal immunization program. Now, hepatitis A has also been included for immunization in children. So, it is a holistic approach from all aspects, but the action main is by the viral hepatitis control program. There is a definite action plan which has to be followed in India. It was implemented in the year 2019. Now, what does it target? It targets, that is, prevention of infection by, see the number, immunization. The target is to provide vaccine of both hepatitis A and B to all children. Next, injection safety, to prevent the transmission of hepatitis B and C virus, especially in the healthcare settings. Safety of blood and blood products, that is, I think you already know, many patients because of various conditions need to be transmitted blood or blood products like fresh frozen plasma or a platelet concentrates. These are all blood products. They can also transmit the infections. So, there is a safety regulations for blood and blood products that has to be followed in all blood collection centers. Okay. In our hospital, we also have a blood collection center. If you are interested, you can go and look for. Next is surveillance of hepatitis. What is surveillance? Surveillance means we have to identify the people who are affected. Which groups of people are more affected? Why this is to be estimated? So that we can take necessary actions against whatever may be the reasons. Okay. Let us say, for example, a very common example have been put forward to you, that migrant population like truck drivers, they are more commonly vulnerable for HIV because of the sexual route of transmission. These group of population are also vulnerable for exposure to both hepatitis B and C. So, we need to know how many of these people are actually affected, then only we can take some corrective measures. Next comes is the diagnosis and treatment. I think this is self-implied. We need to treat each and every specific patient. Okay. More importantly, we need to establish a proper algorithmic management for diagnosis and treatment, because you will see that in some parts of the country, especially in the metropolitan cities, patients are very well taken care of, But if you go to the rural part of the country, most of the time there will be no treatment availability. By the national program, the target is to implement effective treatment throughout the country. Last part is we have to generate awareness not only among healthcare workers but also among common people, because the common people are also affected not only by fecal-oral route but also take into consideration like the people who are involved in waste disposal. There are many rag pickers in the country, they are also very vulnerable. So this is the target. You don't need to remember, just to show you that these are the targets that the government of India have set up. And these programs also run along with other programs like the National AIDS Control Program. Okay, so don't consider that this is a program which runs in isolation. Okay. Similarly, we have program for safety of blood and blood products, injection safety and infection control. There is a proper program known as the Integrated Disease Surveillance Program. The objective of this program is to identify the people who are affected, to get the data. Then the final is the surveillance program for hepatitis. For food and fecal-oral route, we have the Swachh Bharat Mission under the Ministry of Drinking Water and Sanitation. Now this program targets mainly two parts. One is the laboratory services and the treatment services. Now coming to the laboratory services, the program says that laboratory services should be provided at all spectrum of the country. If you look at this pyramid, COE means Center of Excellence. For example, tertiary medical colleges. So we can have the rapid diagnostic test, ELISA, PCR, molecular, all tests are available at the Center of Excellence. But if you look down the pyramid, in the primary healthcare center, we must have the minimum laboratory services, that is the rapid kit for hepatitis B and C. And we should also have a effective referral services so that the patient can be referred from one strata to the next strata. Coming to the treatment part, the target is at the PHC the screening should be done and the treatment should start from the community health center. Okay. Now, this picture shows all the hepatitis. I think you have already read about this, so I am not going to discuss. You have also named all these viruses. Now, let us come to first. I will be briefly going about the 5 viruses and then we will discuss for them. First is hepatitis, these things you can also tell. Hepatitis A spreads by the fecal-oral route. Okay. So, this is the after the infection, the blood gets into the virus, the virus gets into the blood, the virus is also released through the feces and thus transmission continues. After that, there is deranged liver function with raised aminotransferase, and slowly as the antibodies develop, the patient starts to recover. Very rarely, the patient may go into fulminant hepatitis. Next is hepatitis B virus. You are all acquainted with this picture, okay? Fine. Now, one more important, please look at this one. At the initial stage, this stage is called the immune tolerant, initial 2 stages. First is where the hepatitis E antigen comes here, but look at the viral load. The viral load is restricted in these 2 phases. Then we say it is a immune control phase. That means the viral load is less than 2000. After that, the viral load increases more than 2000 units per ml, then we call it as immune reactive phase. If the patient is not able to control, the virus load will gradually increase. Now, why I am showing you this? Recall that in treatment or in the management of these patients, we need to achieve viral control. Why? If a patient has high viral load, the possibility of transmitting the virus from that patient to another patient is very high. But if we can control the viral load in that patient with effective medical therapy, the probability of transmission will also decrease. That means when a patient is under therapy, we need to monitor the viral load. Have you understood? I am not going into the details. It's a something that you will learn later on. Okay, I think you also can interpret this now based on the serological profile. When you will say a recent infection or a chronic infection, chronic infective. Okay, fine. Now, target here is to treat the patient with chronic hepatitis, whether it's a cirrhosis. So, what will be the consequence of chronic hepatitis? What happens actually? If the infection goes on, the viral load is not contained, what will happen? The liver cells will be damaged, and if it's a chronic infection, what will happen? The healing will be by fibrosis. Slowly the liver might become cirrhotic. Some of the patients who will have cirrhosis will ultimately may develop hepatocellular carcinoma. So, the target over here is not only to prevent the transmission, but also prevent the patient going into cirrhosis and hepatocellular carcinoma. Now, hepatitis C virus, it is also transmitted through the same route, and infection with this virus has a higher propensity to cause hepatocellular carcinoma. The only measure that we have right now is treatment with interferons. Okay. There are no vaccines available. So, only preventive strategies is the option for us. Now, this one, hepatitis D. This virus cannot affect singly. Consequently, this virus is infective only along with hepatitis B virus, either a concurrent infection or something is known as superinfection. Okay. So, for that what we need to do? If a patient is diagnosed with hepatitis B, he could also be infected with hepatitis D. So, we need to test for hepatitis D antibody. If it comes negative, that means the possibility that patient is infected with hepatitis D is also less. But if it comes positive, then we must ascertain whether it is acutely infected or chronically infected. If acutely infected, then we need to estimate the viral load for hepatitis D virus. Okay. Finally, hepatitis E. Like hepatitis A, transmitted by fecal-oral route, causes hepatitis, but propensity to cause fulminant hepatitis, especially in pregnant women and children, are very high. Okay. Now, this is the flowchart or algorithm by which we need to diagnose the cause of the hepatitis in a patient who is not jaundiced. Jaundiced means clinically the patient is not eliciting a symptom. So, for them what we need to do? We need to test for all the 4 viruses. Now, why hepatitis D is not included over here? Yes, we will test only if the patient is reactive for hepatitis B virus. So, we need to test for all the 4 viruses. Okay. Then we need to estimate whether any of the test is reactive or not. And for hepatitis B, we have to ascertain based on all the serological aspect of hepatitis B. This is for the non-jaundiced patients. Now, if the patient is having symptoms, sorry, that was with the jaundice. If without jaundice, we need to test only for hepatitis B and C. Clinical symptoms thagle, we need to test all the 4 viruses. Clinical symptoms, we need to test B and C, because hepatitis A and E will eventually derange the liver function and the patient will manifest with clinical jaundice. B and C may or may not. Okay. Now, these are the interpretation. If IgM antibody is positive, that means the patient is affected with hepatitis A. If the total antibody of hepatitis A is present, IgM and IgG, if IgG is present, it is a past infection. If IgM is present, that means it is a recent infection. Uh, Similarly, hepatitis B, I think you can all know. Of hepatitis D, C, you can go through this. Okay. Now let us consider about the vaccines. I have already told you we have vaccines against two viruses, A and B. So for hepatitis A, we have a vaccine, and the WHO recommends the vaccination to be introduced by the National Immunization Schedule for children more than 12 months of age. The two schedules are present. Now in India we have what is known as the Universal Immunization Program. So if you look at the Universal Immunization Program, you will find that hepatitis B A vaccine is given at 12 months. Now what? This vaccine can also be given for adults who have not been previously vaccinated but has a significant chance of getting infected. But now the government of India has stated that all children should be vaccinated. For hepatitis E, there is no established vaccine according to World Health Organization. There are some reports of vaccines being made in China, but until unless an international body like WHO recommends, we will consider that till now there is no vaccine. Now coming to hepatitis B. Now what is hepatitis B vaccine? It is a subunit vaccine. What does it mean? আচ্ছা ঘুরিয়ে কোশ্চেন করছি, ভ্যাকসিন দেওয়ার পরে কোন সেরোলজিক্যাল মার্কারটা পজিটিভ হবে? IgM for anti-HBsAg, right? This surface antigen is required for the virus to enter into the cells. Subunit vaccine means we take that particular segment of the genetic material which codes for this surface antigen, and then we plant this genetic code into the yeast cells. What the yeast cells will do? They will produce the protein and will give us what is known as surface antigen. So if a person produces antibody against surface antigen, what will happen? Whenever the virus enters into the body, those particular antibody will attach at the surface antigen and will neutralize the virus. Now if the virus cannot enter into the cell, it will prevent you from getting infection. Have you understood this? Now this subunit vaccine has both a pediatric version and an adult version. Now pediatric version is given according to the National Immunization Program. The first dose is given what is known as at birth. Okay. Then we have hepatitis B at 2 months, then 6 months, that is 0, 1 and 6. That is for the children. The same regimen can be followed if a child had missed the hepatitis vaccination during their childhood, 0, 1 and 6. Even for adults, we use the same regimen, 0, 1, 6. Sometimes you may even get adults who had been vaccinated with either 1 or 2 doses, but not all 3 doses. Even for them, we will recommend go to the full dose of 0, 1, 6. Next. Now this is talking about post-exposure prophylaxis. Now suppose a healthcare worker gets a needle stick injury with a patient. Predominantly 3 viral diseases we are concerned with. One is hepatitis B, C and HIV, right? Now for hepatitis B virus, what would be the next step of action? It can happen to anybody, a nurse working or say a junior resident working. So we need to ascertain the source from whom the needle stick injury has occurred. So, first the person who has come with the injury, you must ascertain whether that person is vaccinated or not. Now, please remember, when I say vaccinated, that is immunized or not, that means proper immunization, that is full immunization of 3 doses at 0, 1, 6 months and documented. Then only you consider him to be vaccinated. Otherwise, you have to consider him to be as unvaccinated. Next, we must ascertain the source. We must test both the person and the source. Now, if the source may be hepatitis, that is surface antigen, not antibody, antigen may be positive or negative. If antigen is positive, that means the patient or the source is actively infected. So, there is a higher probability of transmission. If the person who is exposed is unvaccinated, then we must administer HBIG. What is HBIG? Hepatitis B immunoglobulin. This must be given as early as possible. Why? Immunoglobulin means antibodies. Even if the patient is exposed in the bloodstream, this antibody will prevent the infection. Now, if the person is previously vaccinated, what will you do? No treatment. You don't need to give anything. Why? I will come to it later. Because take a normal person, you vaccinate him with hepatitis B, what will happen? His body will start producing antibodies, right? We can ascertain by testing for the antibody present. If the antibody present is more than 10 milliunits per ml, we can say that he is protected to a sufficient degree of protection. Okay. We don't need to vaccinate the person. Even if he gets exposed, what will happen? His body will produce even more antibody, right? This is normally what happens. But some patients will not produce antibodies at all, or will produce antibody but will not measure up to 10 units. Okay. If that happens, we will revaccinate once. Okay. Some people may respond slightly delayed. After revaccination, they will have the antibody levels up to 10. After that, we will test again. If even after revaccination, his antibodies levels are not raised, that means that is a non-responder. So, don't try to revaccinate again. How many times you revaccinate them, they will not respond. Okay. This is the reason why you need to test the person who has been exposed. Now, look at this picture. If the person is a known non-responder, then what we will have to do? You will have to give immunoglobulin. Because his body cannot produce the antibody, that means you need to give antibody from outside. Okay. If the patient is undergoing vaccination, what will you do? Suppose he has taken one vaccine and then the incident happened. Exactly. Remember what I told initially? If the vaccination is not completed by the protocol and documented, you must consider him to be as not vaccinated, even though he is undergoing vaccination. Okay? Then what will you have to give immunoglobulin? Okay? Now coming to hepatitis C. So what we need to do? You need to similar like in HIV and hepatitis B, you need to test the source and test the person who has been exposed. Over here there are no vaccines, there is no immunoglobulin. What you need to know? The viral load in the source. Okay. If the viral load is higher, that means the possibility of transmission is higher. So what we have to do? We have to give antiviral therapy to the person who has been exposed, and whether to initiate that therapy or not will depend on his own status and the viral load in the source. Okay. There are specific protocol. I am not going into the detail, which is really out of scope of this class. Okay. I am just giving you the idea behind it. Okay. So whenever a person comes to you with any sort of occupational exposure of blood or blood related products, keep these three in mind: hepatitis B, C and HIV. Remember, hepatitis B transmission in this route can be effectively prevented by vaccination and use of immunoglobulin. HIV transmission can also be prevented by post-exposure prophylaxis. And for hepatitis C, obviously antiviral therapy including interferon therapy. Okay. See the other ways of prevention of hepatitis B, like practicing safe sex with using condoms, and prevention of certain cultural activities like tattooing, sharing of needles, and obviously prevention of injection drug abuse. These are all part of the problem, and a very important part is stigmatization. Why this is important? I will tell you a case I have seen in my own life. So I got a call from the gastroenterology department. There was a lady around about 45 years old. She was basically admitted with decompensated liver failure. The whole serological profile was done. The only positive came was for hepatitis C. Then the DNA estimation was done, and she had a very high viral load. So retrospective analysis was done. Her husband was called, and even her children was also called. They were also tested. None of them were positive. After taking a thorough detailed history, we could only assume, because we could not test that, her last child was born by a cesarean section, and during that procedure she was given only 1 unit of blood. So possibly she acquired that transmission from that one single unit of blood transmission. So why I am telling you this story? Because I want to highlight you that see how a single person's life could be ruined by only single unit of blood transmission. Okay. Then there is a problem with stigmatization, especially for women. They may acquire this infection by other non-sexual routes of transmission, but because of the societal dogma and stigmatization, people will assume, and it is even more in case if a male person is infected, people will then assume various kinds of thing that he or she will be involved in various asocial activities. So we need to counsel the patient. Okay. Not only the patient, we need to make the general public aware about the possible routes of transmission other than sexual routes, so that somewhere we can remove the stigmatization of the patient. Because of the stigma, many a time the patient will refuse to seek any kind of medical advice. Okay, I think I have already told you this one. Now, passive immunization can be given by immunoglobulin. There is a specific dose of 0.06 ml per kg. Combined vaccination is important. Okay, that was all about hepatitis. The second part I want to discuss with you briefly is fever of unknown origin. Even there was a question in your internal assessment question. Now, what is fever of unknown origin? It was earlier known as pyrexia of unknown origin. Pyrexia, as the name suggests, that is, it means burning of the body. But now we call it as fever of unknown origin. So first it was described by Dr. Petersdorf, and they defined as pyrexia of unknown origin was a temperature of more than 101 degree Fahrenheit or higher with a minimum duration of 3 weeks without an established diagnosis. But over the time, as the diagnostic procedures and investigations become much easier accessible and the turnaround time have reduced, this definition is now obsolete. Furthermore, Dura can be divided and classified fever of unknown origin based on the origin, either a classical FUO. Classical FUO means the definition according to Petersdorf, or nosocomial FUO, that means the patient is admitted in the hospital and no cause is elicited, or neutropenic, as the name suggests, patient is having fever, the only parameter that we can see there is neutropenia, and HIV related FUO, that means a patient who is reactive for HIV ceremony. Why they have classified? Because the possible causes are different. When we are looking at HIV related FUO, we are predominantly looking at the opportunistic infections. Okay. For neutropenic patient, there are specific infections which are more commonly associated with neutropenia. We are looking at those causes. Non-infectious causes, this is a non-infectious inflammatory cause. Any sort of inflammation in the body will cause fever. There are many non-inflammatory causes, but the common infectious causes include tuberculosis, Q fever, brucellosis, abdominopelvic abscesses, cat scratch, enteric fever, toxoplasmosis, and extrapulmonary tuberculosis. Now recall the question that was given to you. Importance of blood culture. Why? It can either diagnose or rule out these things, brucellosis, then abdominopelvic, any deep-seated abscess, then enteric fever. Okay. So what happens in deep-seated abscess is that the bacteria is present in that abscess, and at some parts of the time from the abscess the bacteria will spill into the blood. Whenever it spills into the blood, the patient will have a fever spike. Okay. There are other infective causes, like I think you can appreciate subacute bacterial endocarditis. You have read subacute bacterial endocarditis. What happens is that the endocardium, that is the heart, is infected with organisms, and sometimes the organism spills into the blood. Chronic sinusitis, prostatitis, then cholecystitis, regional infection, but organism spills into the blood. There are other many causes like neoplastic causes and miscellaneous causes. These are all can cause fever of unknown origin. Okay. Now, classical FUO is the frequency of each category varies location and time. It is classically seen in patients with more than 65 years of age associated with connective tissue disorder. Nosocomial is commonly seen in hospitalized patient, can also be caused by Clostridium difficile. Okay. Now, what you need to ascertain? First is you need to go through the full history, immunization history, family history, occupational history, travel history. Okay. If you are not thorough in the history, you might be missing out the etiology. Then you might need to do some laboratory or radiological investigations. So these are the laboratory investigations like complete blood count, metabolic panel, urine analysis, chest radiograph, CRP, ESR, LDH, creatine phosphate. They will show the inflammatory process. Along with that, all other like CT scan of abdomen. Why abdomen? Because sometimes abdominopelvic abscess may be very localized, will not be picked up by a radiograph or an ultrasound. Now, next part is for diagnosis of fever of unknown origin, we need to do blood culture. So, what is blood culture? Blood culture simply means we are taking some amount of blood from the patient in whom we are suspecting to have a infective organism, commonly a bacteria or a fungi, and we let it grow in a controlled environment so that we can identify it. This is in simple terms what is blood culture. Today, classically earlier we had what is known as manual blood culture system. Okay. So, what is manual blood culture system? We used to have this kind of bottles, and in those bottles we used to keep brain heart infusion broth. and we take the blood sample of the patient, put it in this broth, and we let it place it in the incubator. Thereafter, we take a small part of the sample and culture on a plate and look whether there is any growth of a bacteria or not. It was thereafter modified by this method. This is known as the Castaneda's method, in which a bigger bottle is used, a higher volume of fluid is used. Furthermore, if you can appreciate, there is a solid agar in the slanted position. So, what is the advantage is, in this bottle, every time we take a subculture, there is a chances of contamination. Every time you are opening the bottle, there is a possibility that you are introducing an organism in it. So, advantage of this method is, we place it in the incubator, every day we just tilt it over the solid agar. Every time we tilt, we are basically making a culture of it. If there is any, then we place it like this. If there is growth on the slant, we can appreciate the colony. This is the Castaneda's method. Now, another advantage of this bottle is, for example, in brucellosis, brucella takes a long time to grow. Most of the time the bottles will get contaminated. But in this bottle, because we are not opening it, we can keep it for about a month. Earlier people used to do subculture every day. Now commonly in the manual culture, what is done is, we do the subculture after 48 hours and then after 5 days and report whether there is a growth there within 7 days or not. This is manual culture. Now see, the problem of manual culture is that two things. First is, it's a labor intensive. We need to take care of each and every bottle, take a subculture, then ascertain the positivity or negative. Another important part is, many a times you will have the patient who is having high spikes of fever, or the patient is in a very poor clinical condition. You cannot withhold the antibiotic in those patients. We need to give the antibiotics initially, then we will consider about the various tests. So, in this bottle we are not doing anything. Whenever we are injecting any antibiotic in the patient, their blood will have the antibiotics, and that antibiotic will also be present in the media. There comes the automated blood culture system. So, what automated blood culture system does is, similar bottles are there and they have liquid media, and along in the media there is something called as resins. What this resins does, it absorbs the antibiotics. So, even if the patient is being given antibiotic, the chances of getting a positive result is higher. Understood? Furthermore, what they have is a disc at the lower part of the bottle. This disc changes its color when the concentration of oxygen in the bottle decreases. If the bacteria grows, oxygen concentration will decrease, the level below will change its color. This color change is detected automatically by the machine. So, the machine detects much faster than a human being can. Okay. So, what will happen? The turnaround time will get decreased. The earlier you get a positive report, you can give the definitive treatment earlier. Okay. So, this is the automated system. Now, even in blood culture, we have the molecular system, a system known as the biofire. What this molecular system does is, we take the blood sample, we test for known pathogens, be bacterial, be fungal, which cause sepsis, that is present in the blood, and we look for the nucleic acid, either DNA or RNA, that may be present by molecular method. What is the advantage over here? We can get the results within 1 day. So, these are the three main methods. Okay. So, if we do enlist, one will be the manual / conventional. The second would be the automated one, and finally we have the molecular. Okay. So, these are the three main methods by which we can ascertain an organism which can cause infection. Okay. So the aims of the blood culture is to prevent the presence of organism, to identify them, and also to perform antimicrobial susceptibility testing for identification of definitive antibiotics for that. Then, in which patient we should always go for a blood culture? If the patient has undetermined fever, shock, chills, rigor, and if the patient is suspected to have specific infections like meningitis, endocarditis, pneumonia, pyelonephritis, or intra-abdominal abscesses. They may be localized infections, but the organisms spill into the blood. Okay. When should the blood culture be taken? Ideally, before giving the antibiotic, but that is practically not possible. So even after the antibiotic is given, you should take the blood culture. More the better. Logic hoche the more the better, but sometimes more is not always possible. If your patient is a child, you cannot take huge amount of blood. Okay. This is the reason why for automated blood culture system, we have specific pediatric bottles. The media is less, so the amount of blood is also less. There are many bottles from 20 ml to 40 ml. Generally, the recommended blood to broth ratio should be between 1.5 to 1.10, but not less than that. So you will have pediatric bottles which have a total volume about 4 to 5 ml. Now, how many blood culture bottles should you send? বলো, এই যে পেছনে ম্যাডাম গল্প করছেন, বলো, এটা বলো, তোমরা বলো। হ্যাঁ, কি বলছো কিছু সবাই মিলে গুজগুজ করে? 2 to 3, 2 না 3, ওরকম আন্দাজে বললে তো হবে না। তুমি ওয়ার্ডে আছো, তোমার সামনে পেশেন্ট আছে, তোমাকে 3টে বটল বার করতে গেলে 15 ml করে দিতে হলে তোমাকে 45 ml ব্লাড ড্র করতে হবে। আচ্ছা, অপশন দিচ্ছি 1, 2, 3, 4। আচ্ছা, 1 কজন বলছো? হাত তোলো। 2 কজন? 3, 4, nobody. Try to understand the logic behind it. Now, blood is sterile. If any organism goes, that means the patient is infected. But there is a high chance of contamination during the process. Yes or no? বেশ, তাহলে আমি যদি একটা সিঙ্গেল বটল নিই, তাতে যদি একটা অর্গানিজম আসে, সেটা প্যাথোজেন না কন্টামিনেন্ট কি করে বুঝবে? ভাবো, স্ট্যাফাইলোকোকাস এপিডার্মিডিস কিনা থাকে তো, আমার লেফট হ্যান্ড থেকে ব্লাড নিলে বটলে গ্রো করলো স্ট্যাফ এপিডার্মিডিস। এবার পেশেন্ট ভাবো ইমিউন কম্প্রোমাইজড, তাদের ক্ষেত্রে তো স্ট্যাফ এপিডার্মিডিসও ব্লাড ইনফেকশন করতে পারে। তাহলে সিঙ্গেল বটল যদি পারো, তুমি বলতে পারবে এটা স্কিনের কন্টামিনেন্ট গ্রো করেছে না সত্যি প্যাথোজেন? পারবে না তো। এবার যদি আমি ডান হাত থেকে আরেকটা বটল পাঠাই, তাতেও যদি স্ট্যাফ এপিডার্মিডিস আসে, তার মানেটা কি? তার মানে হচ্ছে যে দুটো বটলই একই অর্গানিজম, একই সময় কন্টামিনেশনের প্রবাবিলিটি খুব কম। তাহলে দুটো বটলে যদি সেম অর্গানিজম গ্রো করে, the probability is that is the pathogen. বোঝা গেছে? আর একটা কোশ্চেন হচ্ছে, অ্যানারোবিক অর্গানিজম ব্লাডে ইনফেকশন করতে পারে? ইয়েস অর নো? নো। আচ্ছা, কজন বলছো করতে পারে না? হাত তুললো। হ্যাঁ, অব্লিগেট, ফ্যাকাল্টেটিভ ছাড়ো। এরোবিক, অ্যানারোবিক অর্গানিজম ব্লাড স্ট্রিম ইনফেকশন করতে পারে? ইয়েস অর নো? করতে পারে? আচ্ছা, যারা বলছো হ্যাঁ হাত তোলো। আরে লজ্জা পাওয়ার কি আছে? আর যারা বলছো করতে পারে না তারা হাত তোলো। এবার যারা বলছো করতে পারে না তারা বলো কেন করতে পারে না। ব্লাডে অক্সিজেন থাকে, বেশ, ভেরি গুড। কোথায় থাকে ব্লাডে অক্সিজেনটা? আরবিসিতে থাকে, বেশ। এটা কি ফ্রিলি অ্যাভেলেবেল? দ্যাট ইজ মাই কোয়েশ্চেন। ব্লাডে অক্সিজেন থাকে, ভেরি গুড, ব্লাডে কার্বন ডাইঅক্সাইডও থাকে। নান অফ দেম আর ফ্রিলি অ্যাভেলেবেল। ইট ইজ রিলিজড ইন দ্য ক্যাপিলারি এন্ড দ্য পালমোনারি বেড। ঠিক আছে? যার জন্য পালমোনারি ইনফেকশন উইদাউট স্ট্রাকচারাল ড্যামেজ, অ্যানারোবিক ইনফেকশন হওয়ার চান্স খুব কম, কিন্তু ব্লাডে অ্যানারোবিক ইনফেকশন হতে পারে। তাহলে আমি যদি দুটো ব্লাড পাঠাই, দুটোকে যদি আমি অ্যারোবিক্যালি ইনকিউবেট করি, আই উইল মিস দ্য অ্যানারোবিক ইনফেকশন। হতেই তো পারে পেশেন্টের, স্পেশালি পেশেন্ট উইথ ম্যালিগনেন্সিস, তাদের অ্যানারোবিক ইনফেকশন ভেরি কমন। বা ভাবো একটা অ্যানারোবিক অ্যাবসেস হয়ে আছে যেখান থেকে স্পিল করছে ব্লাডে, আসতেই পারে। আইডিয়ালি তোমার ওয়ান সেট অফ এরোবিক, ওয়ান সেট অফ অ্যানারোবিক, সেট মানে দুটো, বোঝা গেছে? তাহলে টোটাল কটা হলো? চারটে, বোঝা গেছে? দিস ইজ আইডিয়ালি, বাট ইন কান্ট্রিজ বা যেখানে রিসোর্স লিমিটেশন থাকে, উই প্রেফার 2 bottles of aerobic rather than anaerobic. রিজন বি, কমন পিপলে অ্যানারোবিক ইনফেকশন খুব কম হয়, কিন্তু স্পেসিফিক পপুলেশন যদি থাকে যেগুলো ইমিউন কম্প্রোমাইজ, ম্যালিগনেন্সি পেশেন্ট, ট্রান্সপ্ল্যান্ট পেশেন্টদের মধ্যে, সেখানে কিন্তু আমাকে অ্যারোবিক কনসিডার করতে হবে। বোঝা গেছে? এবার কোনো কনফিউশন আছে?